Welcome to this training session for SmartEP Vestibular Evoked Myogenic Potentials by Intelligent Hearing Systems. Today I will walk you through the patient and software setup for performing and analyzing a cervical cVEMP and an ocular oVEMP test. Let's first review some basics on the balance system. There are three main components to the overall balance system as described by Aiken, Murnane, and Tampus. There is the sensory input, or the visual vestibular proprioceptive, which provides information to our central processing units. The vestibular nuclear complex and the cerebellum, which manage central processing, and the vestibular nuclear complex, which informs our motor neurons for motor output. There are 5 vestibular sensory end organs. The first 3 are part of the semicircular canal, and they are the anterior, posterior, and horizontal semicircular canals. The other 2 are part of the otoliths, and these are the saccule and the utricle, which is where we understand that the VEMP responses originate from. The function of the sensory end organs are as follows. Semicircular canals sense head rotation, while the utricle senses head translation, and the saccule senses head position relative to gravity. What is a vestibular evoked myogenic potential? The vestibular colic responses are quick reflective changes in muscle tone believed to stabilize the head and by default the body following an unexpected translation. The vestibular response origin is attributed, as discussed in the previous slide, to the vestibular end organs. In particular, the saccule has been implicated as the origin of the cVEMP, and a response pathway has been suggested from the vestibular saccule to the inferior vestibular nerve, the lateral vestibular nucleus, and the lateral vestibular spinal tract to motor neurons in the SCM muscle. Similar implications have been made for the utricle and the superior vestibular nerve as origins of the oVEMP. Let's dive into the VEMP neural connections. Sound stimulates the otolith organs. The nerve impulses travel from the vestibular nerve to the vestibular nucleus. Then the nerve impulses travel in different pathways to the sternocleidomastoid muscle through the medial vestibular spinal tract and to the muscles in the leg via the lateral vestibular spinal tract. These are known as cervical VEMPs or cVEMPs and are recorded ipsilaterally. Here is a different diagram to show the cVEMPs and oVEMPs pathways together. For oVEMPs, the nerve impulses travel from the vestibular nerve to the vestibular nucleus and then to the inferior oblique ocular muscle and inferior rectus via the medial longitudinal fasciculus. These are known as ocular VEMPs or oVEMPs and are recorded contralaterally. Providing some evidence of the oVEMP response and its contralateral characteristic, in an article written by Ian Kerthoids in 2020, titled The Anatomical and Physiological Basis of Clinical Tests of Otolith Function featured in Frontiers in Neurology, Kerthoids states that back in 1969 and 1971, Suzuki and Tokumasu respectively described that the stimulation of the utricle provokes an excitation of the inferior oblique muscles and the inferior rectus of the contralateral eye, as well as the excitation of the superior oblique muscle and the superior recto of the ipsilateral eye. The more robust oVEMP response is from the contralateral eye, and this is why the response is acquired from the contralateral channel. Other important characteristics to note, as established by the studies listed on this slide, are that the VEMP responses are abolished after unilateral vestibular neurectomies, and that there is no correlation between VEMPs and degree of auditory sensory neural hearing loss, suggesting that the VEMP response is not mediated by cochlear afferents. To recap, here is a side-by-side comparison of the characteristics of the cVEMP and oVEMP responses. cVEMP's information originates from the saccule in the inferior nerve function. It is recorded primarily from the sternocleidomastoid SCM muscle. The type of response is inhibitory, and the site of response is ipsilateral. On the contrary, oVEMPs or ocular VEMPs information originates from the utricle or superior nerve function. It is recorded from the inferior oblique ocular muscle. The type of response is excitatory, and the site of response is contralateral. Now let's explore the diagnostic utility of VEMPs, which include primarily the following and is used for the diagnosis of both otologic and neurologic disorders. We have postural instability, especially if EMG is normal, superior canal dehiscence or SCD, or Tullio phenomenon, which you perform the threshold search to look for abnormally large VEMPs at reduced intensity levels, vestibular schwannomas, ear-specific assessment, vestibular assessment of patients with low vision, where you cannot perform vestibular ocular reflex testing. Categorically speaking, otologic disorder applications include but are not limited to Meniere's disease, superior canal dehiscence syndrome, neurolabyrinthitis, vestibular neuritis, vestibular hypersensitivity disorder such as Tullio phenomenon, and auditory neuropathy spectrum disorder. Neurological disorders include but are not limited to multiple sclerosis, spinocerebellar degeneration, migraine, brainstem stroke, lesions and concussions, diabetes, and acoustic neuroenomas. Most of these tumors grow at the inferior vestibular nerve, from which the cVEMP predominantly originates. Caloric tests and oVEMPs mainly reflect function of the superior vestibular nerve. Now let's begin to discuss what affects the VEMP response. When we are evaluating a VEMP response, we are typically interested in both amplitude and latency of the response. The VEMP amplitude is affected by the stimulus characteristics, which include sound level, sound frequency, and duration of stimuli. The VEMP amplitude is also affected by tonic EMG level. Please note that the VEMP latency is not affected by stimulus characteristics, but can be affected by neurological impairment. Stimulus characteristics are affected by the type of presentation being used. The vestibular evoked myogenic potential is an evoked muscular response that is elicited by the presentation of loud sounds such as clicks or tone bursts, tapping or vibrating the skull with a bone vibrator or skull tapper, and galvanic electric stimulation. As presented earlier, VEMP amplitude is affected by tonic EMG level. This EMG level is very important. All of the studies shown on this slide presented the importance and necessity to monitor and quantify the level of pre-stimulus muscle activity that affects the amplitude of the VEMP response. Although VEMPs are currently being acquired using standard AEP systems, most systems do not provide adequate controls to determine if the pre-stimulus muscle activity was at an adequate level. IHS was provided with an SBIR research grant by the NIH NIDCD to study VEMPs with and without EMG monitoring. As you can see in graphs A and B, the amplitudes of P1, baseline RMS, were significantly higher and improved with EMG monitoring, resulting in improved amplitude ratios when the EMG tonic level was being monitored as compared to when it was not being monitored. Thus, IHS developed an innovative and novel method to monitor the ongoing myogenic activity and only average the sweeps that have adequate EMG activity. In addition, a light box and/or an external display provides visual feedback to the patient. Here, we see the Duet VEMP feedback box, which provides visual feedback to the patient and indicates EMG levels by utilizing light-emitting diodes or LEDs. Orange lights will light up for high and low conditions, while a green LED will light up for satisfactory condition. Visual feedback to the patient can also be given via an external display option as shown here. As this image shows, the EMG monitoring display has been moved to an external monitor for the patient to receive real-time feedback on the tonic EMG level. The third feedback option available on the IHS SmartEP VEMP module is mostly used to easily administer VEMP testing to children in order to evaluate their otolithic function. A cartoon or video is used where the video plays when adequate myogenic activity is achieved, as shown on the right, and the video does not play and simply freezes when there is inadequate myogenic activity. Now let's dive into the SmartEP VEMP module and some concepts and definitions that need to be understood before testing is performed. Let's begin by exploring the amplifier settings window. This is where the ongoing EMG waveform is displayed. The user can set and view the low-pass and high-pass filter setting, the amplifier gain, and turn the line filter on or off. These settings control the amplifier into which the raw EMG signals are fed. Now let's draw our attention to the green and red shaded areas or regions on the screen. The green region shows the EMG baseline feedback acceptance region, while the red region is the standard artifact rejection region. Zooming into the VEMP baseline acceptance region, we can see that it is here where you define the start and end times and monitor the EMG feedback. Currently, the software defaults to the pre-stimulus region of negative 79.8 milliseconds to 0 milliseconds. This is typically done in the pre-stimulus portion of the recording in order to exclude undesirable effects from the stimulus artifact or the VEMP response. This region is used to calculate the base RMS amplitude. The average root mean square or RMS of the EMG data contained in the acceptance time baseline region for each sweep is called the sweep baseline EMG level. The sweep baseline EMG level is used in determining if a sweep is accepted for inclusion into the VEMP recording and for biofeedback. The minimum and maximum sweep baseline EMG levels define the lower and upper limits of the acceptance amplitude range, respectively. The acceptance amplitude range is the range of sweep baseline EMG levels greater than or equal to the min and less than or equal to the max. The user enters the desired min and max in the amplifier settings window or by setting these values in the VEMP EMG level feedback window. The allowable range of the min and max values are from 0 to the present maximum amplifier input voltage, which is dependent on the amplifier gain setting. The entered min and max value are displayed numerically after the RMS label. To aid the user in setting the acceptance amplitude range, the positive and negative values for the min and max are graphically represented in the sweep waveform display by the green shaded horizontal region spanning the acceptance time range. During the acquisition of a sweep of EMG, the sweep baseline EMG levels is compared to the acceptance amplitude range. Now let's discuss the artifact rejection time region defined in rejection reg fields and shown between these two downward pointing arrows. The artifact rejection region is defined in the post-stimulus time region, also known as the response region. It works in conjunction with the VEMP acceptance amplitude range to determine if a sweep is to be rejected or included into the VEMP recording based on EMG level. By using the open-close scroll bars or arrows, the user selects the percentage of amplitude range based on the gain value that will be accepted. Any incoming signal within the white area and meeting the VEMP acceptance amplitude range will be accepted, while a signal within the red area will be rejected. With understanding of key terms, we are now ready to review VEMP testing and apply these concepts. We will begin with cervical VEMPs or cVEMPs. The following are cVEMP supplies used for testing. If you're using a duet system, you would use the 5-electrode lead patient cable. To that patient cable and to any OptiAmp system, you would connect snap leads available in red, blue, white on white, white on gray, or black. You will also use Ambu disposable electrodes and skin prep pads to prepare the skin. The cVEMP recording site is the sternocleidomastoid, or SCM, as shown here. It may be difficult to identify the muscle on certain patients, but it is critical that identification of the muscle be as precise as possible in order to ensure the best quality data. To begin cVEMP testing, using a skin prep pad, prep each electrode site and then pat thoroughly dry the area with a paper towel before electrode placement. To acquire and display a positive upward P1 peak response, the positive electrode and leads are placed on the thickest intersection of the upper 1/3 or half of the SCM muscle. Right channel A positive would be connected to the right SCM muscle, while left channel B positive is connected to the left SCM muscle. It is important and crucial that your electrodes be placed in the proper position towards the inside of the SCM muscle and on the same horizontal plane for both SCM muscles in order to ensure that you're not creating a difference in amplitudes artificially across sides. Negative electrode and leads are placed at the bottom of the corresponding SCM muscle, medial 1/3 of clavicle. Right channel A negative is connected to the right bottom SCM muscle, while the left channel B negative is connected to the left bottom end of the SCM muscle. The ground electrode is connected to the forehead. For an inverted negative inflection P1, reverse the polarity of the connections by switching the inverting and non-inverting inputs. When placing the snap electrodes on the patient, make sure to press around the white edge of the electrode to adhere the electrode to the skin. Do not press on the center of the electrode sensor, where the sensor sponge is located, since this area is conductive and the conductive gel may spread and compromise the adhesiveness of the electrode. If impedances are high, remove and discard the snap electrode. Remove any conductive gel on the skin and re-prep the skin with a skin prep pad. Pat thoroughly dry the electrode placement area and reapply a new electrode. Electrodes that are not conductive may require a dab of SpectraGel on the sponge area. Do not use electrodes that are expired, dried, or have been exposed to the elements. Once the patient is set up for testing, it is time to enter or load the patient information into the software via the patient menu. Then load the VEMP acquisition parameters via Load Settings on the control panel found at the bottom of the acquisition page of the SmartEP software. The system includes two pre-installed settings files, cVEMP.set and oVEMP.set. For cVEMP testing, you will load the cVEMP set file. The settings file contains the following parameters. Stimulus frequency is 500 Hz Blackman with 2-cycle rise and fall times. Intensity is 98 dB NHL, equivalent to 120 dB SPL. Polarity is rarefaction. The rate is 5.1 per second. We will be testing the ipsilateral side of stimulation using insert earphone. The sweep count will be 50 sweeps. Please note that you can choose to change the sweep count to include more averages all at once. For example, some run 100 sweeps altogether, 150 sweeps altogether, or 250 sweeps altogether. But IHS recommends the batches of smaller sweep counts in order to reduce muscle fatigue. Between every average of 50 sweeps, there should be a rest period of approximately 15 to 20 seconds. You can acquire up to 10 recordings of 50 sweeps for a total grand average recording of 500 sweeps when it's all summed together. You can also acquire 2 runs of 50 for a total of 100 sweeps, or 3 runs of 50 for 150 sweeps, or 5 runs of 50 for a total grand average of 250 sweeps. Remember, the more sweeps you have for your grand average, the better the signal-to-noise ratio and the baseline. Moving on to the amplifier settings, we use a 5K gain, a 10 Hz high-pass filter, and a 1000 Hz low-pass filter. The sampling rate is 5 kHz with a 200 microsecond acquisition time window, which is 102.4 milliseconds of pre- and post-stimulus data. The display time window is typically 0 to 102.4 milliseconds, but you can adjust your display window to what you wish to use. The rejection region is 6.2 milliseconds to 102.4 milliseconds. The default artifact rejection level is 45%. Please note that this can be opened or closed depending on your preference. It is typically turned off for superior canal dehiscence patients, and thus artifact rejection level should be 100% for those types of patients. The VEMP acceptance region is set to a pre-stimulus region of negative 79.8 to 0 milliseconds, and the minimum and maximum RMS is set per patient. The most critical part of doing VEMPs is ensuring correct electrode placement, EMG contraction, and setting up the acceptance amplitude region correctly. In setting the acceptance amplitude region correctly, we turn to the EMG monitoring display screen, which will read the input from the channel of acquisition. This is based on the ear-stimulated and mode selection, IPSI or contra, set up on the control panel. Make sure these settings are set correctly when you are reading amplitudes for setting up your acceptance amplitude range. What this means for cVEMP is that if you are acquiring right IPSI channel A, then you are positioning the patient in a bed at 30 degrees and asking them to lift their head and shoulders slightly off the bed or pillow and turn their head to the left to activate the right SCN muscle. The EMG microvolt amplitudes will be read from the right channel A electrodes, and the EMG feedback screen will show right as circled in orange here. If you are doing cVEMPs and acquiring left IPSI channel B, then you are positioning the patient in the bed at a 30-degree angle and asking them to lift their head and shoulders slightly off the bed or pillow and turn their head to the right to activate the SCM muscle on the left. The name of the channel displayed on the feedback display will turn to left, and EMG microvolt amplitudes will be read from the left channel B electrodes. Lastly, make sure the muscle is active and in position or engaged before starting acquisition. The VEMP EMG level feedback window displays biofeedback and also allows the user to input the acceptance time region and acceptance amplitude range parameters. In the acceptance range frame, the user can manually enter the min and max voltage values for the acceptance amplitude range or utilize the calculated range features. The user can select acceptance amplitude range values that are patient-specific. This is accomplished by observing the patient's right and left side muscle activity before the VEMP testing is started. One method is to have the patient activate their right side muscle and then activate their left side muscle, noting which side produces the larger EMG levels. Then setting the acceptance amplitude range max value based on the side with the larger EMG levels, and the min value based on the side with the smaller EMG levels or an absolute minimum value. In order to use the EMG range calculation frame, let's discuss what this is in more detail and how it works. The right side, left side, and EMG range calculation frames are provided to assist the user in setting the acceptance amplitude range min and max values. The most recently acquired sweep baseline EMG levels for the right and left amplifier channels are displayed adjacent to the right side and left side labels respectively. These levels are updated every 500 milliseconds. The right side and left side max values are the maximum sweep baseline EMG levels that occurred during the running average time selected by the user in the EMG range calculation frame. The right and left max levels are updated every 500 milliseconds as well. The right side and left side mean values are computed by calculating the arithmetic mean of the baseline EMG levels acquired during the running average time selected by the user in the EMG range calculation frame. The right and left mean values are also updated every 500 milliseconds as well. To aid the user in selecting the min and max values based on the ongoing EMG activity, the SmartEP software allows the user to set parameters to calculate and display min and max values on a running basis. The calculated range value displayed for the right and left sides are calculated using the following equations. The recommended min equals the measured max times 0.7 minus the percent range times the measured max. The recommended max equals the measured max plus the percent range times the measured max, where the percent range setting is selected by the user in the EMG range calculation frame. These calculated min and max values are updated every 500 milliseconds. The user can copy any one of the calculated range values to the acceptance range entries by pressing the Apply button next to the min and max fields, or pressing the Apply Both button to copy both the corresponding min and max values. The user can also manually enter the max and min values of their own choosing into the acceptance range frame. During VEMP recording, the selected acceptance amplitude range values applied to both right side and left side amplifier channels. The purpose of providing biofeedback is for the patient or device operator to utilize the biofeedback information so that the patient maintains a satisfactory level of muscle contraction during testing. The height of the bar in the bar graph in the VEMP EMG level feedback window displays the most recently acquired sweep baseline EMG levels for either the right or left amplifier channels. The horizontal lines on the bar graph represent the acceptance amplitude range min and max levels set by the user. The patient biofeedback provided via the external display option is as follows. When the sweep baseline EMG level is less than the acceptance amplitude range minimum value, the low level condition, the bar displayed is shaded in pink, and the face displayed is a blue sad face. When the sweep baseline EMG level is greater than or equal to the acceptance amplitude range minimum value and less than or equal to the max value, the satisfactory level condition, the bar displayed is shaded in green and the face displayed is a yellow happy face. When the sweep baseline EMG level is greater than the acceptance amplitude range maximum value, the high level condition, the bar displayed is shaded in pink and the face display is a blue sad face. The bar graph and face displays are updated every 500 milliseconds. Please note that if the patient is constantly below the set minimum and always rejecting sweeps, then the minimum may have to be lowered, and if the patient is consistently above the set maximum and always rejecting, then the maximum may have to be increased. The patient biofeedback provided via the VEMP feedback LED box option is as follows. When the sweep baseline EMG level is less than the acceptance amplitude range minimum level, the low level condition, the bottom orange LED is illuminated. When the sweep baseline EMG is greater than or equal to the acceptance amplitude range minimum level, and less than or equal to the acceptance amplitude range maximum level, the satisfactory level condition, the middle green checkmark LED is illuminated. When the sweep baseline EMG level is greater than the acceptance amplitude range maximum level, the high level condition, the top orange H LED is illuminated. Let's tackle setting a sample acceptance range. As a reminder, the patient should be lying down at a 30-degree angle and will be asked to lift their head, neck, and shoulder off the pillow slightly and to turn their head to engage the appropriate SCM muscle. Please note that some patients may need modifications to activate the SCM muscle. Some may use a technique like pressing their hand against the cheek to apply force and to engage the SCM muscle. The clinician will need to evaluate what is the best technique for their setup, conditions, and patient. Once again, ensure that the RMS min and max values are set properly per patient according to their contraction capacity, and in order to ensure that you are not rejecting unnecessarily while ensuring adequate muscle activation. Typically, max is selected for the stronger side, and min is applied for the weaker side. To do this, set ear to right and mode to IPSI. Lift and turn to the left side. Engage the right SCM muscle and read the calculated range maximum for the right side channel A, which is highlighted. Then, set the ear to left and mode to IPSI. Turn to the right side and engage the left SCM muscle and read the calculated range maximum for the left side channel B, which is highlighted. Next, identify the stronger side, which is defined as the side that has the greatest maximum calculated range. Then set the ear to the stronger side and turn to the opposite side to engage the SCM muscle. Once the patient is engaged on the stronger side, click on Apply next to the max field on that side. Next, set the ear to the weaker side and turn to the opposite side to engage the SCM muscle on the weaker side. Once the patient is engaged, click on Apply next to the min field on that side. Once these values have been applied, you will see the following acceptance region populate with the applied numbers. As the clinician, if you ascertain that the patient is able to provide higher minimums and higher maximums, then you can adjust the acceptance range to obtain the highest amplitudes from your patient. Please make sure that you are not fatiguing the patient by rejecting excessively. If you find that the minimum is set too high for your patient because they cannot reach the minimum microvolt level set and are rejecting constantly and fatiguing the muscle, then you may need to lower your minimum acceptance region. Please note that rejections are based on acceptance range as well as post-stimulus EEG artifact region. Now, before starting to test, it is important that the artifact rejection range post-stimulus be set correctly. IHS default settings files have the artifact rejection set to 45% for each channel, but you may need to open that up to a higher percentage for cVEMPs. Some patients may require artifact rejections to be set at 70% or even 90% to reduce rejection and patient fatigue. Have the patient contract and view the EEG for the appropriate channel. Adjust the artifact rejection accordingly. You can toggle between channels by selecting the button labeled CHA or CHB for channel A and channel B respectively. For suspected superior canal dehiscence, clinicians can turn off the post-stimulus artifact rejection by opening to 100% for both channels, as shown in this screen display, and saving this as part of your settings file. Now you can begin testing. Make sure to begin testing after the patient has activated the muscle for the side you are testing. You do not want to click the Acquire button until the muscle is active and engaged. Thus, ask the patient to turn their head to the opposite side of the stimulus when the adequate condition is achieved, then click Acquire. Now let's review EMG data processing. First, a sweep of EMG data is collected in conjunction with delivery of a single stimulus. If any of the EMG data samples in the rejection time region are greater than the rejection amplitude level, the sweep is rejected. The sweep baseline EMG level is calculated. If the sweep baseline EMG level is within the acceptance amplitude range, the satisfactory condition, the sweep is accepted, and the biofeedback for the sweep is classified as satisfactory. Otherwise, for a low or high level condition, the sweep is rejected. If the sweep was accepted, the sweep is added in the VEMP recording arithmetic mean, and the acceptance sweep counter is incremented. This process is repeated until the accepted sweep counter value equals the user set sweep count, or sooner if the data acquisition is terminated by the user. Once VEMP recordings have been acquired, the user can add waveforms for a grand average and label the grand average for display and analysis purposes. For the purpose of this video, we will acquire 3 cVEMP recordings of 50 sweeps for a total of 150 sweeps per ear. Once the patient is engaged and the EMG level feedback is adequate, click on Acquire. You will see the sweep counter begin to increment. When the 50 sweeps are complete, rest for 15 to 20 seconds. Then instruct the patient to engage again and click Acquire. Repeat this process for each ear until the number of total sweeps have been acquired. You will note that we are acquiring the left ear and acquiring ipsilaterally. Thus, the EMG feedback is being read from the left channel. Once you have completed one ear, change the ears. Engage the right SCM muscle by turning to the left, and when the EMG feedback is adequate, click Acquire. Once all recordings are complete, select Arrange by Acquisition Order by clicking the O in the toolbar shortcuts or the O on your keyboard. To calculate the grand average for each side, press the Control key to select all recordings and choose Process, and then add selected recordings or Shift+ on your keyboard. Now select the 3 raw recordings for each ear. Click and drag each one and arrange and overlap them on the bottom of the screen. Your grand average VEMP recording will appear in bold at the top of the screen. Label your recordings P1, N1, and make sure to drag the amplitude marker of P1 to the N1 location. The P1 amplitude is calculated to be the data amplitude value at the P1 peak marker minus the data amplitude value at the P1 trough marker. The P1 latency is the time value of the P1 peak marker. You can use your right and left keyboard arrows to make adjustments to the latency label marker, and the Alt plus the right or left arrow keys to make adjustments to the P1 amplitude marker. Save the grand average recording via the Recordings menu and Save Active Recording option, or choose the Save All Recordings from the shortcut toolbar. Finally, compare the recordings by doing a multi-selection of both left and right grand averages using your Control key to select the waveforms, and then choose either Process Compare Selected or from the Rec Info panel, as shown here via the Compare tab, obtain the asymmetry ratios. Use the Add to Page option to add the information to your data results page. Finally, save your report through the Report menu or through the shortcut icon Save Report and assign a file name. If you wish to load the report at a future date, simply load the patient and then select Load Report. The recording information analysis provides or includes the file name for each grand average recording, the ear stimulated, base RMS amplitude for each response, P1 latency, P1 amplitude, and P1 corrected amplitudes for each recording, asymmetry ratio and corrected asymmetry ratio, and the P1 latency difference, which is the absolute mathematical difference between the P1 latency values of 2 selected right and left side recordings. VEMP test interpretations have been focused primarily on amplitude or threshold asymmetries between the right and left sides. The asymmetry ratio is determined by selecting 2 VEMP recordings, one each for the left and right side. Using the following asymmetry ratio, where P1L and P1R are the P1 amplitudes for the left and right recording respectively, the equation is amplitude on the left minus amplitude on the right divided by amplitude of the left plus the amplitude of the right. Taking that absolute value and multiplying it by 100 will provide you the asymmetry ratios. Clinicians have found that asymmetry ratios of greater than 35% are clinically significant. There are 2 camps in the VEMP analysis world: those that use straight asymmetry ratios and those that prefer to use the corrected asymmetry ratio. You can refer to the work of Walgampola and Kolbach and others on the use of corrected asymmetry ratios. To further account for level of tonic SCM muscle activity, The SmartEP system uses a measure of the pre-stimulus EMG activity to normalize the P1N1 amplitude, and then automatically calculates both the asymmetry ratio and the corrected asymmetry ratio. Now we need to revisit the concept of correcting the asymmetry ratio and what that means. To recap, base RMS amplitude is calculated within the base activity region, also known as a baseline. The user marks or confirms the settings for the start and end time to define the base activity region. The start and end times are typically in the pre-stimulus portion of the recording in order to exclude undesirable effects from stimulus artifacts or the VEMP response. The base RMS amplitude is the average root mean square of the data contained in the base activity region, calculated using the equation shown here, where n is equal to the number of data points contained in the base activity region, and xi is a data point value contained in the base activity region. The base RMS is used for calculating the corrected P1 amplitude. The standard asymmetry ratio is further processed to provide a corrected asymmetry ratio, which is based on P1 corrected amplitudes. To calculate the corrected P1 amplitude, the P1 amplitude is divided by the base RMS amplitude. In other words, amplitude corrected equals amplitude marked divided by the RMS of the marked EMG baseline. The corrected asymmetry ratio uses the P1C corrected amplitudes and is calculated using the following equation, where P1CL and P1CR are the corrected P1 amplitudes for the left and right recordings, respectively. Now let's move on to oVEMP testing. The following are oVEMP supplies for testing. Use an electrode skin prep pad for cleaning the skin. Ask the patient to close their eyes during the cleaning process. Make sure to dry the skin thoroughly with a paper towel. If using a duet system, you would continue to use the 5-electrode lead patient cable. To that patient cable and to any Opteon system, you would connect the following electrode leads: reusable gold cup electrodes or AMBU disposable cup electrodes. The cup electrodes will require 1020 conductive paste and surgical skin tape to adhere the electrode to the skin. The oVEMP recording site is the inferior oblique muscle, as shown here. Electrodes should be placed at the intersection of the inferior oblique muscle and the inferior rectus. Load the oVEMP settings or the oVEMP.set file via the Load Settings button on the control panel, or create your own settings file. Most of the settings for oVEMPs are the same as the cVEMP. The main differences are we will be testing from the contralateral side of stimulation, and the gain is 100K. All other parameters are the same as listed here. Make sure that Electrode Montage is set up as follows for oVEMPs. The positive electrode must be placed on the lower eyelid at the intersection of the oblique inferior muscle and the inferior rectus. It is important that special attention be taken with this electrode placement, as clinicians may erroneously place the positive electrode below the lower eyelid and not on the muscle at all. This will affect your amplitudes. Your negative electrode is placed 2 centimeters below your positive electrode, and your ground electrode is placed on your forehead. Because of the sensitivity associated with the eye area, it is imperative that you use gold cups or lightweight disposable AMBU cup electrodes for oVEMP testing. Do not use heavy snap electrodes and leads in this area of the eye. Once electrodes are placed correctly, check impedance. Impedance should be balanced across all leads and as close to 1 kiloohms as possible. Next, muscle activation is obtained by staring and looking up maximally at a 45-degree target. It is most advantageous if the patient is instructed and tries their best to not blink during testing. The 45-degree target is achieved by sitting in a chair that is 38 inches away from a baseline horizontal target position, and then measuring 38 inches upward from that horizontal target to obtain your 45 degrees. oVEMPs are slightly different from cVEMPs in that once you look up maximally, both eyes and muscles are activated simultaneously. Thus, it is easier and faster to obtain the RMS min and max values by simply analyzing the muscle activation once. Also note that there are great differences in amplitudes between cVEMPs and oVEMPs. Where cVEMP responses ranges in the hundreds values, oVEMPs are much smaller responses and average in amplitudes in the 10 microvolt to 30 microvolt range. Thus, it is important that when moving from cVEMPs to oVEMP testing, or vice versa, that you reset the amplitude acceptance range accordingly per test. Ensure that the RMS min and max values are set properly per patient according to their contraction capacity in order to ensure you are not rejecting unnecessarily while making certain adequate muscle activation. oVEMP RMS ranges also vary by age of the patient, with minimums as low as 1.4 microvolts at times for very elderly patients. Verify the patient's range, especially their minimum microvolt, and set accordingly so as not to fatigue or reject the response. Once the patient is ready for testing, view the incoming EEG. Ask the patient to blink. Make sure to set the artifact rejection level to reject the eye blink artifact on each channel. Once the patient is ready and test parameters are set, select Acquire to record the oVEMP responses. As with cVEMPs, it is recommended that you take 10 recordings of 50 sweeps for each ear for oVEMPs as well. Make sure that the patient rests between each 50 sweeps for at least 15 to 20 seconds to reduce fatigue effect and rest the eyes. The patient should close their eyes during their rest periods in order to minimize fatigue. Once all the recordings have been acquired, then sum the recordings to obtain a grand average of 500 sweeps per channel. Calculate the grand average for each side. Control to select all recordings and then Shift+ to add them. Save the grand average recording under the Recordings menu and the Save Active Recording option. Label your recordings in a similar fashion as was discussed with the cVEMP demonstration. Note that unlike cVEMPs, for oVEMP recordings, the N1 trough occurs and is labeled prior to the P1 peak. Make sure to drag the amplitude marker of P1 to the N1 location. Next, compare the recordings. Do a multi-selection of both left grand average and right grand average and choose Process Compare Selected, or view the Compare tab in the recording information screen to obtain asymmetry ratios. VEMP recordings will either be absent, reduced, enhanced, or delayed, as shown in this table when the pathologies listed present themselves in the patient. At the time of this recording, the American Speech and Hearing Association, ASHA, has announced that beginning in 2021, audiologists can report VEMP testing with new CPT codes for ocular and cervical vestibular evoked myogenic potentials. Centers for Medicare and Medicaid Services accepted the recommended values from ASHA, American Academy of Audiology, American Academy of Neurology, and the American Academy of Otolaryngologists. The CPT codes are 92517 for cVEMP testing and 92518 for oVEMP testing when performed alone. A bundled CPT code 92519 should be used when oVEMP and cVEMP testing are performed together on the same day. Intelligent Hearing Systems makes no billing recommendations. In conclusion, VEMPs are an important addition to the vestibular test toolbox. VEMPs provide diagnostic information about saccular and inferior vestibular nerve function, as well as the utricle and superior vestibular nerve function. VEMP amplitude is affected by stimulus characteristics and EMG tonic muscle activity. And due to the improvements to the asymmetry measures achieved by the reduced variability in muscle tension, EMG monitoring during acquisition, as available in SmartEP, is important. We hope you've enjoyed our VEMP training presentation. If you are interested in any of the compatible lines available from IHS, or if you are not currently a Duet user and would like more information on this innovative clinical solution, please contact our sales team at sales@ihsys.com. Thank you for watching this training video. If you have any questions or suggestions, please contact our support team at support@ihsys.com.